Okay, so this is the lecture on cardiopulmonary health for the PTA208 special topics class as requested by the class. The lecture itself is 78 slides. Lecture is provided on Blackboard for your viewing pleasure. So let's talk through cardiopulmonary health. So cardiopulmonary health is health dealing with the respiratory system as well as the cardiovascular system. So let's just look at the respiratory system, right? Respiration is the process of gas exchange between the alveolar air spaces in the blood. Ventilation is the movement of air in and out of your lungs. So when you're breathing, you're doing both ventilation and respiration. Either one of those there can be a problem. Respiratory failure is typically caused by impairment of that gas exchange and usually causes reduced interpulmonary gas exchange or reduced movement of the gases in and out of the lungs. Can be caused by any number of things, but that'll ultimately indicate increased carbon dioxide in the blood, decreased oxygen in the blood. Can be caused by airways, disorders of the airways, lungs, skeletal, muscular, and neural components. So there's all kinds of things that can cause it. The respiratory system, anatomy itself. The skeletal system that works with respiratory is primarily the thoracic vertebrae, the sternum, the ribs, and everything that kind of makes up the thorax. Muscular components of the respiratory system, primary would be the respiratory stuff, primary breathing, the diaphragm, and then all of your accessory muscles such as, your pecs, your intercostals, your upper traps, everything like that. So here's kind of the movement of the actual respiratory system as things move. The diaphragm does descend with inhalation and then raises with expiration. So here's the overall layout of the lungs. Now we talked about this when we were talking about percussive therapy. The major difference between the right and the left lung is the left lung does have the cardiac notch specifically for the heart. So respiratory physiology, most breathing is under involuntary control under normal resting conditions, meaning that it's controlled by your brain. It's also controlled by chemicals, so your chemoreceptors. Airways and pulmonary vessels are under a degree of autonomic control, right? But we can increase our breathing rate or decrease our breathing rate via motor cortex. The ventilatory pump system controls the volume moving in and out of the lung airways. Compromised lung volumes and capacity are also often associated with restrictive lung disease. And compromised flow rates are associated with obstructive. So when capacities and volumes are compromised, it's usually a restrictive disorder. When flow rates are compromised, typically it's an obstructive disorder, right? So going back to this, restrictive meaning lack of the ability for the lungs or the chest cavity to expand. Obstructive meaning there's a blockage somewhere in the actual lines. So arterial gas physiology here, right? We have arterial alveolar oxygen difference, the difference in O2 concentration between the arterial blood and the air within the alveoli. You have ventilation, which refers to the movement of the volume of air from the atmosphere in and out of the airways. Perfusion of the lungs refers to the amount of blood flowing through the lungs, right? The perfusion pretty much anywhere is how much blood is flowing through the area. Ventilation perfusion must match for adequate gas exchange, meaning there must be enough air coming in and enough blood to accept that air for adequate gas exchange to occur. Respiration involves the acquisition of O2 by the blood and the expiration or elimination of CO2 from the blood. Arterial blood gases are measures of the partial pressure of oxygen, PaO2, and the partial pressures of carbon dioxide, the levels of bicarbonate, and the pH levels of the blood. The work of breathing is the amount of energy or oxygen consumption needed by the respiratory muscles to produce enough ventilation or respiration to meet the metabolic demands of the body. Remember, the body is always going to have a metabolic demand when we're talking about oxygen, as long as the body is alive. So here's kind of what it looks like as far as the gas exchange occurs. So your normal pH usually exists between 7.35 and 7.45. I usually think of when I'm looking at the test for your boards is normal pH is between 7.25 and 7.5. Respiratory acidosis typically they say is under 7.35, but again, if you're going to get a board question on this, the number is going to be a lot lower. So it'll say something like 6. That would be a patient in respiratory acidosis. Where a patient that's an 8 is in respiratory alkalosis, or metabolic acidosis or metabolic alkalosis, depending upon what we're looking at. So it's going to depend upon a couple of volumes. Good news is you don't have to know all of this. You do have to know your pHs though. So you know that if they're below 7, they're in acidosis. If they're above 8, they're in alkalosis. It doesn't matter which one's causing it. So respiration, obviously, airway resistance is the force opposing airflow in the airways. So if you're having trouble breathing, resistance could be the problem. Now we talked about elasticity before, right? Elasticity is not necessarily the ability to expand, but it's the ability for things to return to their original shape. So the ability for the chest wall to expand and then return to its normal shape, which also talks about compliance. Surface tension refers to the cohesive state that occurs at the liquid-gas interface. So at the alveoli, there is a certain surface tension that allows the air, and oxygen, and carbon dioxide to be exchanged. The membranes on top of that, and usually has to do with the surfactant, which is basically the WD-40 of your lungs. So here's kind of what normal lung compliance looks like. And if you look, emphysema, you can see that it just does not have as much compliance as it does with normal lung breathing, right? And then fibrosis definitely worse off. So pathophysiology, problems that could happen. Hypoventilation occurs in a state of decreased or inadequate ventilation. Can be CNS depression, neurological disease, disorders of the respiratory muscles, any that can cause hypoventilation, meaning that you are not taking in enough air when you're breathing. Ventilation perfusion mismatch results in impaired gas exchange. So if they're not getting out enough CO2 or they're not getting in enough O2, that can be a ventilation perfusion mismatch. Diffusion abnormalities increases the overall work of breathing by interfering with the gas exchange. Respiratory failure can be classified as primary hypoxic or primary hypercapnic, depending upon if we're talking about the problem being with the actual oxygen or with the capillaries themselves. Hypoxic respiratory failure is primarily characterized by abnormal low partial pressures of O2 and close to normal partial pressures of CO2, meaning that the CO2 levels haven't changed, but we're not exchanging it, and we're definitely not giving the patient new blood levels or new oxygen levels. Hypercapnic, the problem with the capillaries, is characterized by an abnormal elevated partial CO2. So at that point, the capillaries are not letting out the CO2. If they don't let the CO2 out, then O2 is not going to come in. So how do we know? We're going to take patient history. What the patient understands to be the cause of respiratory. What do they know, right? We talked about this chronic pain as well. What do they know? How the patient's respiratory function has evolved over time. Have they had repetitive blows to the chest? What's causing them to have these problems? Current and prior activity tolerance is kind of important to know as well. And then also, need for supplemental oxygen. Do they need supplemental oxygen or not? If they do, then we have to know that. And if they have to have supplemental oxygen, we need to know that while they're in the clinic, because they should be on supplemental oxygen while they're in for therapy. Medications, what kind of medications are, how those affecting those lungs. Upper extremity, lower extremity range of motion is going to be important for this, strength and endurance, and joint integrity. If they're having problems moving their shoulders, that can lead to a respiratory problem. So we need to make sure we assess their full upper body range of motion and strengthening. Or strength. Tests and measures. We can measure cognitive reflexes, sensation, coordination, motor function, pretty much anything to kind of look at it. And then we also look at the skin, right? We need to make sure that the patient doesn't have any fibrotic skin changes that could cause them to have other problems down the road that's not allowing them, right? Because if your skin is not elastic enough, then obviously when you're breathing in and out, that can cause a problem where you may not be exchanging gas as well. Patients on ventilators and receiving more O2 are likely to have poor O2 transport and greater dependency on supplemental O2. This is why it was important with COVID here, is because as soon as a patient goes on the ventilator support, their body starts not exchanging gas at their normal rate because the body starts doing less and less work. ABGs, arterial blood gases, oxygen saturation, and non-invasive carbon dioxide measures are needed. You need to listen to the heart, oscillation of the heart and lungs, right? And then we also get heart rate and blood pressure for any of these patients. We need to make sure that it's not a heart problem instead of a lung problem. Chest wall and abdominal motion will be examined, observation of the breathing pattern, movement is the upper and lower extremity and the upper and lower chest. Chest expansion will be measured, how far can they actually breathe in and how far can they let it out. And then looking at stuff like bed mobility transfers, the overall level of function is important as well. Our goals with a patient that's got some sort of a lung problem is directed at preventing the problem or preventing the problem from getting worse or preventing any secondary complication from that problem. The last thing we want to do is a patient with a with say COPD or something like that, is let them go into some sort of pulmonary failure because of the flu leading to pneumonia or something to that effect. The ultimate goals of patients requiring prolonged mechanical ventilation are minimize loss of mobility. Again, as soon as they go on that ventilation, the body's going to stop doing as much work as it can, and so they're going to decline. And we need to make sure of that. So that means we need to mobilize them as much as possible. Here's kind of from your rehab book, the possible outcomes for patients receiving mechanical ventilation. You don't have to know all of these, but I did put them there in case you encounter somebody that's got mechanical ventilation. Supplemental O2 is indicated when the patient cannot or can sustain sufficient work of breathing. So this is supplemental O2 is when they have an oxygen line. This means they can breathe fine. The work of breathing is fine, but they can't maintain adequate levels of oxygen, right? All O2 systems consist of a supply source and delivery source. O2 is usually delivered from supply to the patient by a nasal cannula or face mask. The dose of O2 can be delivered and expressed in terms of flow rate, usually in liters per minute. So a lot of times you hear the patients are on 2 liters, 5 liters, 10 liters, something like that. Because O2 is a prescription based on the FDA, they have to have a prescription for it because it is considered a medication. And then mechanical ventilation substitutes or assist the patients in the ventilator pump, right? So if they go on the ventilator, that means that they're actually getting a mechanical system for the work of breathing and maybe also for the oxygen levels. 4 basic routes of intubation are the nasopharyngeal, oropharyngeal, endotrach, or a tracheostomy. So either cutting them open or putting it down their nose, throat, anything to that effect. So there's controlled ventilation, assisted ventilation, and assist control, right? So controlled ventilation means that the machine is going to control the ventilation levels. Assisted ventilation, right, means that they're going to assist with the actual moving in and out of the lungs. And then assist control is to help control, make sure the patient's not taking in or taking in too much or too little. Good news is with ventilation, there's a lot of stuff on here. The good news with ventilation, most of this is going to be managed now by your respiratory therapist. There's not as much we need to worry about when it comes to mechanical ventilation anymore. When they're coming off that mechanical ventilation, we need to wean them. Just like any medication, it needs to be allowed to develop strength and endurance so the respiratory muscles can actually breathe on their own. When weaning for mechanical ventilation, more energy will be needed for breathing, meaning that they'll have less reserve for other things. So a lot of times when patients come off mechanical ventilation, they'll complain that they're just constantly tired. Well, that's because even just that work of breathing is burning through calories that they, weren't used to burning through. Any form of assisted ventilation where an endotracheal tube is not used, it's usually provided by a face mask. So if they have a mechanical ventilation where they're forcing air in via a face mask, it's non-invasive, but again, it's still going to cause problems with the lungs. Positioning adjunctive techniques for clearance and secretion. We talked about this already, right? So you have postural gravity drainage techniques where you put them in those specific positions like we showed on that slide and let gravity do the work of pulling out the fluids, or we can do percussive, right? And in percussive, we can actually kind of clear it out with percussing the chest wall or thorax wall. Either of those is acceptable. If you are doing percussive therapy, you should also teach the patient postural drainage. So they should know how to lie to allow those secretions to exit their lungs. Again, clearing the upper lobes first and then moving to the lower lobes. They should be doing functional exercise training. Overall, they should be doing some sort of exercise. The more they exercise, the faster they'll wean off of either oxygen, supplemental oxygen, or supplemental ventilation. IMT, inspiratory muscle training, this type of exercise that involves using a device that provides resistance for inspiration, right? Those are those nice little things that usually the patient has sitting over on their heaters of the rooms, called an inspirometer. They should be using those as much as possible. And studies demonstrate that those actually can improve pulmonary function, increase that overall function, right? And decrease wean time. So the more they are using their inspirometer, the better their chance of getting out of the hospital. And then we also have to make sure we take care of any behavior problems, right? And they need to sleep enough. They need to worry about their fear. We need to stop smoking. Anything to that effect must be modified as well. All right, moving on to the cardiac system, right? Structural causes of heart failure include disorders of the myocardium, pericardium, endocardium, or great vessels, right? Either the vena cavas or the aortas. All of those would be structural causes of heart failure. Restrictive cardiomyopathy means the walls of the ventricle become stiff and do not expand as well. Hypertrophic cardiomyopathy is characterized by thickness of the walls of the heart. So having a big, thick heart is not always a good thing. And then dilated cardiomyopathy is characterized by stretching and thinning of the heart muscles. So you can have either too much, too thick of a heart, too thin of a heart, or just where the heart just becomes non-functional and becomes less elastic. So here's kind of what they look like, right? Dilated cardiomyopathy, everything looks thin. Hypertrophic, right? At that point, the heart's gained some gains. And now those ventricles aren't as able to hold as much fluid, right? Restrictive, everything becomes fibrotic. And then we have our normal heart, which the normal heart itself just has a normal shape and is not either too big or too little. It's just right, like Goldilocks. So types of heart failure we can encounter. Well, it's usually classified by whether it affects systolic or diastolic blood pressure, right? Systolic dysfunction can further be categorized as ischemic or non-ischemic, blocking or non-blocking. The prognosis for patients with ischemic heart failure is worse than those for non-ischemic. So if you have heart failure where you're getting a block, that can be a major problem. Diastolic heart failure is usually detected after exclusion of other possible reasons. So if we finally get down to where we're looking at the patient having a diastolic heart failure, we've probably gone through everything else we can possibly go, and now the patient's at a point where they're really bad. The New York Heart Association classification system classifies patients with heart failure into one of four classes, according to their degree of symptom with rest and activity. The symptom most commonly used by physicians to prognosticate, so look and monitor the patient's overall interventions in heart failure. Oops, so there it is there. So no symptoms, symptoms with ordinary exertion, symptoms less than ordinary exertions, or symptoms at rest. So obviously if they're having symptoms at rest, that is the worst a patient could possibly be. Characteristics of heart failure. Many patients with significant heart failure with very low levels of exertion, such as brushing their teeth or walking to the bathroom. Just imagine that. If you're starting to get tired just by brushing your teeth or just getting out of bed, you've got some pretty bad heart failure probably. Patients with heart failure may only achieve half the normal increase in cardiac output during exercise, meaning that if they exercise, they're not getting normal cardiac output. We need to be monitoring for that, right? Sorry, I didn't mean to move forward. And then we have to monitor their pressures, listen to their heart, everything like that. So we should be monitoring vitals of every single heart patient that's out there. Take a patient history, and of course we're going to measure the patient, right? Do range of motion, flexibility, muscle testing, all that fun stuff. So here's BMI. We talked about that before. Now BMI may not be the best predictor of if a person is truly obese or is not obese, right? But if they have a high BMI, that gives them the chance of later developing heart issues, cardiac issues. Even if that increased BMI is caused by increased muscle mass, it still can potentially lead to cardiac issues down the line. We're going to measure cognitive deficits, right? Perceived pain or breathlessness, which we can measure on the 0 to 10 scale. Angina can be rated on the 1 to 4 scale. And then dyspnea can be also rated on a 0 to 4 scale. Again, dyspnea being shortness of breath. So here's the angina scale. This is talking about chest pain. 1 is kind of just mild, but they recognize it, and it's just there. It's a familiar feeling. 2 is some pain, moderately severe, unable to tolerate. And then 3 and 4 are, oh boy, I'm having a heart attack level. There's the dyspnea index. Examination, therefore, will include test measures in fluid accumulation, jugular venous distension, heart rate, anything like that. So the PT's really got to look into everything in the human body to figure out what might be causing this heart failure. It can cause fluid retention that presents with symmetrical lower extremity swelling, right? And gains of up to 3 or more pounds in 3 days because of that fluid. Jugular venous pressure will be elevated in patients with heart failure because they cannot pump blood out of the heart adequately, thus causing blood to accumulate in that venous system. A heart rate and rhythm are often indicators of patients' physiological status and prognosis, right? We're going to listen to the heart and hear what it sounds like. Abnormal heart rhythms, or arrhythmias, cause approximately 50% of the deaths in patients with heart failure. If that heart suddenly stops beating or starts beating at a really odd pace, that's an arrhythmia. So therefore, it's important for us to monitor the heart. If we have a heart patient, they need to be on telemetry if possible. Telemetry is where they're hooked up to the system, and the system is measuring their heart rate, because not always can we do that. It's not like we can just every 5 seconds be checking their heart rate, right? Because we just don't have that ability. Blood pressure is used to assess systemic perfusion. It must be measured at least baseline and then after each intervention. So if you have a cardiac patient, a lot of times you're going to be measuring blood pressure before therapy, in the middle of therapy, after therapy, sometimes even several times during therapy. So that means you need to be able to get that blood pressure down quick, right? Heart sounds can be heard by putting that stethoscope on the patient's heart wall and listening. And then lung sounds are assessed by chest oscillation, actually listening to the chest, usually from the back. So METs can be determined by an exercise testing, right? METs is the metabolic equivalent levels that help determine how much energy a patient's burning. It also helps determine ventilatory gas exchange, right? How much oxygen is being used. 6-minute walk test is one of our common ones, right? That's what we did with the cardiac or aerobic competency, where we did that 6-minute walk test. They can do echocardiography. So an echo provides information about the size of the heart, chambers, thickness of the heart valves, right? And other information. Then a heart cath is where they actually go in and look at those blood vessels with a camera. So that's where they're going to stick a camera up through your vein or your arteries and try to see what they can see at those arteries in the heart. 2 disease-specific measures have been developed for assessing quality of life in patients with heart failure. The LHFQ and the KCCQ. All those are out there. You don't have to specifically know each of them by heart, but just know that they are both out there. Aerobic exercise is any continuous activity that involves rhythmic contraction of the large muscle groups and increases the rate of aerobic metabolism. Potential benefits include improvement in central hemodynamics, such as increase in cardiac output, heart rate, stroke volume during exercise, and decrease in cardiac demand at rest. Appropriately selected aerobic exercise can be helpful for patients with all classes of heart failure, meaning that if they have heart failure, that doesn't mean they stop exercising. They actually should be encouraged to exercise more. Isometric exercises, though, specifically isometric resistance, should be kind of avoided in patients with heart failure because that increases that overall pressure and increases the afterload on the heart. Moderate resistive training is okay. We just want to avoid that prolonged isometric hold. Interval training allows muscles to work harder than they could with a steady state of exercise, right? So giving them time to rest, time to recover, and then go back into it. 3 main important factors that affect the risk of exercise with heart failure are the patient's age, the intensity of the exercise, and the presence of ischemic disease. Exercise should be avoided during periods of heart failure decompensation, meaning if the heart can't compensate for the problem that's going on, they probably shouldn't be exercising. So there's kind of relative contraindications for heart failure that I left in there. Exercise mode. The exercise prescription will include some form of aerobic exercise. Brisk walking can elicit adequate training in those patients with heart failure. So even if they can just walk, it still can improve their cardiac function. They should be exercising as much as they possibly can, right? Generally, they want to at least exercise 3 to 5 times a week if they can. That would be the ideal goal for them, right? And they should be exercising when they reach, that 4 to 6, 4 to 5, 5 to 6 range on the RPE when we're using the modified RPE. Patients with heart failure can tolerate initial intensity ranging from 40 to 70% of peak VO2. So we're going to have to kind of be looking at that to be tested, right? We're going to look at their heart rate and determine how much are we going to allow the heart rate to go up with this as well. Progression of patient with low initial exercise capacity would generally make faster initial progress. Those who are at higher functional capacities to start with usually don't make as much progress because they're already at a higher capacity to start with. Heart transplant. This is where we take the heart out and we transplant it with a new one, obviously. May be indicated in patients with end-stage heart failure that is refractory to optimal pharmacological support, meaning if we can't manage the heart with drugs, they may have to look at a heart transplant. It should be a last resort because, they can produce good outcomes. There's all kinds of other complications that go wrong, right? What if they put the new heart in you and the heart doesn't want to start? So there's all kinds of things. But if they do get a heart transplant, exercise is a huge, huge, huge part of the comprehensive post-treatment plan, right? There are mechanical assist devices that can be used to provide either temporary or permanent support for the failing heart. There's intra-aortic blood pumps, ventricular assist devices, cardiopulmonary bypass machines, and then there's the LVADs, right, that help with everything overall in general, so that when you have left heart failure, that they may have to help pump the blood out of the left side of the heart. So we talked a little bit of percussive therapy, right? We have our upper tracts, right, of the respiratory system. They warm, moisten, and filter the inspired air. This is where bacteria is usually trapped by the nasal cilia and the mucosa. So we have the nose, the paraspinal sinuses, and the pharynx and larynx is the upper tract. And we have the middle tract, which is the trachea, and the lower tract, which are the left and right main bronchi, then the smaller bronchi, and then the alveolar bronchi, the alveoli, and the lobules. All of that is kind of the breakdown of that respiratory system. So pulmonary circulation, the lungs receive deoxygenated blood from the heart, right? With that blood flow technique, oxygen returns to the heart from the inferior superior vena cava, enters the right atrium. The right atrium is a small contraction. Mainly, it's a pressure-related gradient. So it starts filling up, it gets a certain pressure, and then dumps into the right ventricle. Right, and the right ventricle is at its capacity. Tricuspid valve closes, preventing backflow of the heart, and then the right ventricle will then contract, and blood will leave through the pulmonary valve and travels through the pulmonary arteries to go to the lungs. Right, from the lungs, it'll go there into those arteries of the lungs, get reperfused with oxygen, return back via the pulmonary vein to the heart to the left atrium, right? Go through the mitral valve down into the left ventricle, and then up through the aortic valve back to that actual aorta. So the capillaries are the main spot of oxygen transfer as well as carbon dioxide transfer. So we need to make sure they are functional, especially in patients with COPD. Those become reduced ability to actually become elastic, so they may not function as well anymore, right? At the level of separation between the alveoli and capillaries, there's only one cell thickness, right? The barrier between the alveoli and the blood vessels is about 1 micron, which is this hugely tiny number, 1/10,000th of a centimeter. The lung then exhales carbon dioxide of the body, and the blood returns to the heart via the aforementioned pulmonary veins, right? Respiratory system's primary function are respiration, respiratory defense system, and acid-base system. Ventilation, respiration, we talked about already. We already talked about the muscles of respiration. So restrictive and obstructive, I want to talk about. You need to get this down. This is one of the biggest things you're going to get with heart and lung problems, right? Restrictive in the heart or the lungs is the inability for the system to fully expand and or return to its original shape, right? Typically occurs from extrapulmonary restrictions, so outside the lungs, in the lungs. With the heart, it can be outside the heart or the heart muscles themselves. Obstructive means blockage, right? It can also be ischemic in the heart, right? So obstructive is a condition that which obstructs the flow of air in the respiratory tract, excuse me. Having a ton of pollen could cause that. There's all kinds of reasons that could cause kind of that obstructive problem. So here's some examples of restrictive issues. Tumors, interstitial pulmonary fibrosis, bronchopulmonary dysplasia, advanced age, fibrotic change, trauma, surgery, scleroderma, ankylosing spondylitis, there we go. Postural deformities such as scoliosis, SCI, CP, MD, PD can always cause this. Pleural diseases and obesity or ascites or swelling of the abdomen. So that means that anything that's limiting the excursion of the chest and or chest wall, that is a restrictive disorder. Obstructive, this is where we get a blockage. Peripheral airway disease, meaning a problem with the peripheral airway is the first one. Chronic bronchitis, chronic emphysema, chronic asthma, bronchiectasis, cystic fibrosis, and bronchopulmonary dysplasia are all examples of obstructive blockages. So chronic bronchitis is defined as a chronic cough and expectoration, so goo comes out, which persists for at least 3 months for at least 2 consecutive years. So they're not going to be diagnosed with chronic bronchitis for at least 2 years while we're monitoring them. They've got to have 3 months for those 2 years combined. Emphysema is defined as the abnormal enlargement of the distal respiratory units, right? So this is where the alveoli becomes abnormally distended and do not return to their normal shape. Now, the alveoli do not become fibrotic, meaning they are not hardening, but they just are not as elastic as they used to be. And then COPD is where chronic bronchitis and emphysema come together, right? And their symptoms overlap. It's usually described to talk about the combination disorders. So the patient does not have chronic bronchitis, emphysema, and COPD. They have chronic bronchitis, emphysema, so therefore they have COPD. Corpulmonale. This is an important thing to know. It's considered a severe medical emergency. It is a sudden, extensive dilation of the right ventricle due to pulmonary embolus, meaning that the blood's starting to back up into that right atrium and the right ventricle. It's usually a blood clot in the lungs. Right-sided heart failure will occur almost immediately if not treated, right? So if patient suddenly gets a chronic cough that goes along with angina, and then uniform bilateral swelling, dyspnea, shortness of breath, fatigue, and malaise, they're probably going to Corpulmonale, and they need to get into a hospital to determine where their blockage is occurring. So what can we do here? Well, medical management. We want to talk about managing the airway patency, so the ability for it to actually move. We can give them beta-adrenergic agonists like albuterol to help relax the airways, anticholinergics, which help the body prevent spasming. Bupropion, Atrovan is also there. The problem with this is we have to monitor those because common effect is respiratory depression, meaning that it may actually cause all kinds of problems to go along with it, right? We talked about anti-ACH drugs back when we talked about myasthenia gravis, and we talked about myasthenia gravis having that myasthenic crisis where the lungs suddenly just shut down, right? And that was a pretty serious problem and side effect of myasthenia gravis. Corticosteroids can help. Supplemental oxygen as well can help. Surgical resection of the giant bullae to remove abnormally dilated non-functional lung tissue can occur as well. But again, anytime that we do surgery in the lungs, that's where we're going to get into trouble. So they want to try to avoid even the pneumonectomy as well, where they remove some of the non-functional lung. You can do a lung transplant for terminal conditions, but again, just like the heart transplant, it's very risky. And physical therapy is a really good intervention for lung problems. Breathing education. We may need to teach them diaphragmatic breathing, right? Where they're going to breathe in through their nose, fill up their belly, expand their ribs, and then they're going to breathe out. So that airway clearance techniques and ACBs and ACDs, all that. Pursed lip breathing is good for COPD patients because we're teaching them to exhale longer than they're inhaling. Patient education. They need to stop smoking. We need to teach them energy conservation so they can maximize their overall energy function. Exercise, ventilation, muscle training. The more they do aerobic exercise, the more they're going to start using their lungs. It can also then help them clear out things. So we may need to do secretion reduction or removal. Talk about positioning. If they're having problems sleeping in one position or not sleeping in one position, we need to analyze that to see if it's caused by the lungs or the heart. And then also teach them relaxation techniques, which is probably one of the biggest problems we have nowadays is people just don't relax enough. We'll teach them to increase ventilation, improve oxygenation, therefore relieve dyspnea. You talked about this in Therex too. Smoking cessation, special focus on the side effects of smoking, so how smoking cessation affects the body. Right? We can guide the horse to water, but we have no ability to make the horse drink. So that means we can't force the patients to stop smoking, but we can do our best to try to encourage them to stop smoking. But if they don't, ultimately, their lung problems aren't going to get better. They're actually going to get worse. Use of resistive breathing trainer to help improve muscle function is important. Right? We talked about the inspirometer. Aerobic exercise. Any form of aerobic exercise serves to stimulate and improve respiratory capacity. Be aware, if you're going to increase their aerobic capacity, they have to have a warm-up and they have to have a cool-down. You need to teach them proper exercise technique, not to just jump in and start running at 7 miles an hour or something like that. Trunk and lower extremities. Any exercise that affects the shoulder or trunk will help mobilize the chest. Right? Seated toe touch to open V's are common, where they're going to put their hands kind of like they're praying and put them down between their feet. And then they're going to sit all the way up and open their chest real wide and open to a wide V. High trunk arm rotations are good, right? Any type of trunk rotations are good as well to help it. We talked about percussion, vibration, shaking already. Coughing is also really good. You talked about that with Dr. Ovreskin. Assisted cough is nothing more when the patient's going to cough. You're going to almost give them an abdominal thrust to help force out anything that's stuck there. And then suctioning. You will be expected to know how to suction if you're working in a place where you're going to deal with people that have a lot of suctioning. The good news is you should get trained on it. There's no way I can really teach you how to properly suction without a patient that actually has the problem. So if you have a patient that needs suctioning, make sure you get the appropriate training before you just stick a tube down their throat and start sucking out gunk. Position the patient according to the bronchopulmonary anatomy. So if the particular lung segment is placed with the bronchus perpendicular to the floor, we talked about that when we were talking about percussion therapy, right? Trendelenburg works well. Reverse Trendelenburg is the exact opposite. Doesn't work as well to help clear it, but tilt tables are really useful for helping clear the lungs. If they put them in Trendelenburg, remember there can be some problems with that, right? So they're upside down, so the blood is more rushing to the head. So you have to be thinking about this. Is it going to increase pulmonary edema or decrease pulmonary edema? What happens with the heart when all of a sudden the heart's getting that return rapidly because of gravity? Is the blood pressure going to go up, right? Anytime we go to that position, that is actually increasing blood pressure. So if you have a patient that's got, hyperreflexia or autonomic dysreflexia, and you invert them on the table, that's going to jump their blood pressure rather than low it. And then abdominal problems, right? If they have abdominal distension, anything like that can cause problems. So be aware, talk to them, find out their shortness of breath in those positions, find out their exertion while they're in those positions, and be sure to get constant feedback from the patient. Just another picture of that we talked about already, right? Side-lying positions, right? We want to make sure that we have precautions here. If they have an axiofemoral bypass graft, right, it can cause problems if they're in side-lying. Musculoskeletal, arthritis, recent rib fracture, any of that can be problems for side-lying. Be aware that you have to be thinking of what problems the patient has. Postural drainage must have the patient cough or perform suction before changing positions. We talked about it, but limit the total treatment time to 30 to 40 minutes if treating the more than one section of lungs. I told you about it. You're going to do about 5 minutes or so of percussive therapy, and another 3 minutes of clearance. You can apply manual facilitation while the patient's in these positions. We talked about percussion already. 2 to 5 minutes per lung segment, which is what I told you. And there's your precautions for this. I'm going to move on since we already talked about it. You can also give an a cappella device, which can help force kind of clear it out because they have to breathe a lot harder to exhale, and that's going to help pull stuff up. That's kind of what the a cappella looks like. The various types of coughing techniques. Double cough, which I think is what Dr. Reskin talked to you, which is followed by a deep inspiration, and the patient performs 2 coughs in 1 breath. The second is usually more forceful than the first. Remember, if they have any type of surgery, they may have to brace and splint. Huffing, the patient takes deep inspiration, the air is forced out, except the mouth is kept open, right? That huff. Usually huffing is going to be clearing the upper parts of the bronchioles more than the lower parts. Excuse me. Heimlich technique can be used to assist for coughing. Just make sure you're not on that xiphoid process. You need to be inferior to the xiphoid process, pull up and in. Rocking. If they rock forward while they're coughing and taking deep breaths, it can help clear out a lot faster because you're getting some vibration to go along as well. Positions that relieve dyspnea. Positions that support the upper extremities, such as leaning forward or tripod positions, are recommended to increase mechanical efficiency of the accessory muscles, right? It also increases the intra-abdominal pressure and helps push the diaphragm up for exhalation. Combine positioning with other techniques, such as breathing and coughing, to further promote drainage, right? So tripod position is probably one of the best positions you can put a patient in if they're having dyspnea or shortness of breath. How we assess them, we already talked about all these, right? Move on. Breathing pattern. When you're assessing their breathing, you need to be paying attention. How are they breathing? Are they a nose breather? Are they a mouth breather? Right? And then look at how easy is it for them to breathe in and out? What is the ratio? Right? Are they breathing in and out at the same ratio or not? Look at their posture. Look what's accessory, right? Are they shoulder breathing? And they shouldn't be, right? Where your shoulder told them about it before. And then look at the overall size and shape of the thorax. They have one side that's larger than the other that could be causing problems with that lung. Look at their nail beds, right? So if their fingers are kind of stubbed off and clubbed off, that's a definite sign of lung failure, and it could also be heart failure as well. So you're looking for your fingers to kind of club off. Palpation for mid-diastole shift, right? So we're going to feeling up their throat to make sure that everything is in the position it should be, that it hasn't shifted. The trachea will typically move towards an affected side of the lung. Palpations for fremitus, we talked about this. Place the palms, the inner eminences, lightly on the symmetrical areas of the back, and have the patient repeat 99 repetitively. And then we're going to compare the vibrations, right? You can also compare from the front and from the sides if you come right under kind of the arms themselves. Under normal condition, vibration should be equal. Increased fremitus with increased density in the lung tissue, right? Decreased when there's fluid in the space. So if they have fluid and they're a little bit more congested, you're going to notice a decreased overall vibration count. It'll be a greater vibration if they have nice, clear airways. Oscillation, listen, right? Listen for everything, especially listening for those adventitious sounds. How do the sounds happen, right? Are they normal, soft, low-pitched? Are they wheezing, right? Are they abnormal? Is there something that's causing pneumonia that's causing it? Is there decreased breath sounds on one side versus the other? Are there absent breath sounds? So you're listening and you hear no air exchanging down in maybe like the inferior lobe. That can be a sign of pneumothorax or a lung collapse, so pay attention. Are there crackles? Sounds like the rustling of cellophane or the popping of bubble wrap, right? Is there wheezes, where it's kind of a wheeze, right, when they're breathing? Bronchi, the low-pitched occurs with inspiration, expiration, where it's a really, right? And then stridor is a very high-pitched wheeze that you could hear in the lungs. If you hear that, and you hear it without a stethoscope, you can hear that very high-pitched wheeze coming from the lungs without a stethoscope. That can be a real emergency. And like patient that's got myasthenia gravis, that's typically a sign of a myasthenic crisis coming. Oh, all these numbers again. You have to know all these. I try to put these on one chart here for you, right? That means here's your normal formulas. That means you have to know this chart inside and out. There is not an easy way I can teach you this chart. The only thing you can do is study it, right? You have to know what the difference between total lung capacity and inspiratory capacity is, and then inspiratory reserve volume and tidal volume. The main questions they are going to ask you on is on tidal volume and then inspiration versus expiration comparisons. So you do have to study this. There's no easy way I can teach this to you, right? Blood gases help us determine the effectiveness of the alveolar ventilation, right? Are we looking at the partial pressure of oxygen, partial pressure of CO2, and then that acid-base pH, which we've already talked about. Talked about aerobic conditioning, or you should have talked about this in Therex. Carvinen's formula is the KTHR, determine your heart rate, determine resting heart rate, and then you subtract resting heart rate from maximum heart rate times the intensity plus the resting heart rate is given in target heart rate. For example, here's a nice example of it. That is a lot better for patients that have a high resting heart rate or a patient that's in heart failure. For most of us, we can just do our target heart rate by looking at our max heart rate, right? So say you're a 40-year-old adult, you take 220 minus their age, so 220 minus 40, their max heart rate then would be 180, and then doing a percentage of that. So say they're going 80%. You just do 80% of that 180, and that'll tell you where your target heart rate goal would be, right? But for a patient that has a super high resting heart rate, you know, if your goal is, you know, say you have a 70-year-old patient, that 70-year-old patient's maximum heart rate is 150. And say you want to hit 80% of that, well, that could be, you know, say you want to hit 50% of that 50% could be 75 beats per minute, and their resting heart rate is 80. Just at rest, they're already at their target heart rate. So you may have to adjust things based on the resting heart rate. Again, intensity should be 20 to 30 minutes, 2 to 3 times a week. 3 to 5 is most ideal. They may require periods of rest, which is fine. And when they're rehabbing from any type of lung or heart problem, typically it's going to be 6 to 8 weeks in duration in outpatient. That's it for this lecture. So for this lecture, the other thing to majorly remember is you do have those medications to worry about. The main thing about medications, again, is safety. So the main thing with safety is looking at, you know, making sure that if your patient is on a pulmonary medication or a heart medication, you are consistently and constantly measuring their vitals before therapy, during therapy, and after therapy. You have to have those vitals every single time in your documentation, because that'll help document that what you're doing is actually helping the patient. Thank you for listening to this, and you guys have yourself a good day.